Okay, I think we better get started. First of all, I would like to welcome everybody to today's seminar and thank you all for joining us. So today's seminar series is part of the many that we've been doing previously, and there's more to come. So I'll just want to urge everybody to keep an eye on previous seminars we've done, plus also others that will follow after this. But today, we're very excited to do a series on health information systems, and we're going to be listening to a variety of talks, both from different from the Next 360 program, but also from Vermont, Oxford. We hope that this is a very interactive session. For those who are joining us today, we do encourage you to, if you have any questions through the presentation, please do put them on the chat, and the panelists today are going to try and respond to those comments. So in terms of introductions, my name's Eric Ohuma. I'm an associate professor of medical statistics at the London School of Hygiene and Tropical Medicine. And it's my pleasure today to moderate today's session. So in terms of what to expect, so we have several talks. We're going to start with Dr. Danielle Ehret, who's going to be talking to us about the Vermont Oxford experience and how it's been linked to the data set that they're working with the African Neonatal Association. So very exciting outcoming from that. And then after that, we're going to also hear from Dr. James Cross, who's going to be talking to us about a neonatal inpatient data set for small and sick newborns that's been implemented in several countries in Africa. And then Dr. Gagam Gupta is going to be telling us some of the experiences from the India, which has been really been a key piece of information for us once we've been thinking about the data set we've developed for neonatal inpatient data set. And then we also have some time to kind of have questions and answer sessions as well. So we hope that we can have plenty of time to answer any of the questions, but also keep the chat going as well if you have any questions throughout. And then we'll have some closing remarks at the end. So without further ado, I'll pass on to Dr. Danielle to take us through the Vermont Oxford experience and the LMIC dataset from Dr. Alex Stevenson. Over to you. Thank you.
Thank you so much, Eric. I'm Danielle Ehret. I'm a professor of pediatrics and the Asfa Yamaru Professor of Global Health at University of Vermont, and proud to be the Chief Medical Officer and Director of Global Health at Vermont Oxford Network, presenting with Dr. Alex Stevenson today.
Hi, I'll introduce myself. I'm Alex Stevenson. I'm a neonatologist in Harare in Zimbabwe. I'm also the president of the African Neonatal Association, and I'm a co-PI in the African Neonatal Network, which we'll be hearing about later.
Thanks so much. Well, we're just so proud to be presenting today on behalf of the Vermont Oxford Network and talking about our experience, highlighting our co-development of a database for use in low resource settings as one integral tool for data-driven improvement. We'd first like to thank the organizers, our colleagues at the London School, Nest 360 and UNICEF for organizing these fantastic webinars and the ongoing creation of the Newborn Implementation Toolkit. Next slide, please. Oh, next one. So I'm going to start with a brief background on the Vermont Oxford Network, referred to as VON. VON began back in 1988, led by Drs. Jerry Lucy, Jeffrey Horbar, and Roger Saul at the University of Vermont in the United States. The basic philosophy of the network was to integrate research into daily practice by designing simple, pragmatic studies that are compatible with the demands of busy health professionals and relevant to the questions that arise in daily practice. This philosophy was based on concepts developed by Ian Chalmers, Adrian Grant, and co-workers at the National Perinatal Epidemiology Unit in Oxford, England. We started with teams at 34 hospitals in 1988, initially with members in the US and UK, utilizing a standardized database for benchmarking, learning, and improving. Although our origins are in Vermont and Oxford, we are now proud to be a community of healthcare professionals and families at more than 1,400 member centers in 34 countries and growing, collaborating to improve neonatal care around the world with data-driven quality improvement and research. Next. Our mission is to improve the quality, safety, and value of care for newborn infants and families through a coordinated program of data-driven quality improvement, education, and research. And our vision is a worldwide community dedicated to giving infants the best possible start so that every newborn and family achieves their fullest potential. Next slide, please. Working together as a community, we have set the challenge to reduce neonatal mortality and morbidities, especially in our high-risk preterm population. When we first introduced the challenge, focusing on dramatic reductions of death and late onset infection in very low birth weight infants more than a decade ago, we were met with great skepticism that this could even be achieved. Deaths and infections at that time, especially in this high-risk population, were considered unavoidable. However, since that challenge was first posed, median infection rates for very low birth weight infants reduced from a little over 20% in 2005 to less than 10% in 2019. Mortality had a relative decrease of more than 30% from a median of 14% down to 10% in the same time period. The graphs on the left show the median hospital rates in red, the 25th and 75th percentiles in the blue dashes, and the 10th and 90th percentiles in our organization in blue dots. Along with improved median rates, variation or the spread between those lines has also reduced. We now extend that challenge for improvement to all of our major morbidities. This improvement is possible when neonatal teams believe and see that it can be done, are supported by leadership and improvement efforts, and learn from each other. The bar graph on the right shows that by 2019, 100% of centers were achieving the rates of mortality and late onset infection that were celebrated by only the top 10% of hospitals in 2005. We are better learning together, and there is still important work to be done, particularly in morbidities such as necrotizing enterocolitis or NEC, severe intraventricular hemorrhage, severe retinopathy of prematurity, and chronic lung disease. Another challenge to our community is that our responsibility to families extends beyond the hospital walls. The ingredients to a successful learning community are not unique to geographic space. In fact, our vision is to contribute to our worldwide community, adapting, co-creating, listening, and deeply learning together. The global challenges are urgent and demand collaboration and hopefully shared celebrations. Next slide. Since 2008, Vaughan has partnered with colleagues in Ethiopia, initially under the leadership of Professor Bogali Worku in capacity building and supporting the first neonatology fellowship. We are committed to the continued success and professional development of our graduates, now all Ethiopian neonatal leaders, and the families they serve. Following graduation, the next steps were clear: to add support of an advanced practice neonatal nursing program at Addis Ababa University under Dr. Azrat Dempsey's leadership, and establishment of a standardized neonatal database similar to the other Vermont Oxford Network databases, suitable for benchmarking, quality improvement, and advocacy in the Ethiopian setting. Valuing our wonderful partnership, we've been hard at work on both of these challenges. We co-designed, tested, and refined a standardized database initially at one hospital, St. Paul's Hospital Millennium Medical College in Addis Ababa, under Dr. Malet Abena's leadership. And following its success, we expanded with the support of the Ethiopian Federal Ministry of Health and the Ethiopian Pediatric Society to more than 20 public hospitals in all regions of the country. Next slide. Emphasizing the purpose is not data collection, but data use and data-driven improvement. We paired the rollout of the database with hands-on quality improvement workshops for all participating hospitals, bringing the lead neonatal physicians and nurses together for collaborative learning. Initially, teams identified gaps to work on, with 3 themes naturally emerging. Teams worked on training delivery room providers with helping babies breathe or neonatal resuscitation. Next. Reduction in admission hypothermia for inborn admissions. And the next slide. Receipt of kangaroo mother care for infants with birth weights under 2 kilograms. Teams shared progress, challenges, run charts as shown here, change ideas, and improvements. Next. A standardized database and quality improvement training has allowed for a shared language and community-driven agenda setting. Reflecting on local data and the system of care, we completed a root cause analysis for the high preterm mortality rate due to respiratory distress syndrome in Ethiopian NICUs. Our participating hospitals asked the question of why are preterm babies dying of RDS in our NICUs, followed by why, and why, digging deeper to determine the root cause. These were completed by multidisciplinary team members at multiple levels of care. We consolidated responses and teams voted and reached consensus on the root cause, the inability to provide high quality CPAP. Next. With the challenges that COVID brought, we were able to pivot and funneled the outrage about preterm mortality and the desire to improve CPAP and optimize into a grand challenges project to use the foundation of our database and quality improvement knowledge to focus on implementation of the national guidelines on RDS and telementoring to link each ENN hospital with a nurse physician CPAP mentorship pair. Next. During a time when teams could not physically travel or hold in-person trainings, our CPAP mentors remotely trained and retained 385 NICU nurses and 66 physicians, approximately 75% of the ENN nurses and physician cadre. The national algorithm uses a modified Down score for assessment for respiratory distress, and this top run chart shows this practice has been adopted into routine practice and sustained with consistently 95% of infants having a score completed and recorded on admission. Another success of this project was the creation and adoption of a standard vital sign sheet for infants on respiratory support, surpassing the goal of 75% of hospitals adopting this new practice. I try to follow the advice of my mentors: no data without a story and no story without data. We are so proud that our data has led to improvement, strengthened and empowered a multidisciplinary community, fueled advocacy locally and internationally, sparked conversations, and fostered networking and new partnerships, with our Ethiopian colleagues leading the way to development of an African neonatal network. And I'll now pass the baton to my colleague and dear friend, Dr. Alex Stevenson, president of the ANA.
Great, thank you, Danielle. Exactly. I mean, it's a linear story building on the successes and ongoing successes of VON and the Ethiopian Neonatal Network. It's the obvious next step is to expand this to other sites and other countries in Africa. And so the African Neonatal Association is very happy and proud to join VON to set up the African Neonatal Network, which is a quality improvement collaborative designed for low-income settings for centers in Africa. So we're very grateful to be funded by Gates for 3 years. And we're starting off in 5 countries. You can see those: Ethiopia, Nigeria, Rwanda, Uganda, and Zimbabwe. But definitely are hoping to enroll more centers and more countries in the coming years and going forward. So at the moment, I think we've got about 18 hospitals participating, but we're hoping that each year we will introduce a whole lot of new hospitals. So the next slide, please. It starts with data. It starts with standardized data and high quality data, and data that you can believe and data that you can use, because it's, as Danielle mentioned, it's not about having a database, it's actually about quality improvement. Our standardized data collection sheet is deliberately small and hardly legible because I didn't want to spend the presentation going through it. But if you go to our African Neonatal Association or ANN website, you can see it. You can also link with that QR code. But I think what is important is that we're trying very hard to have the oranges and with oranges and the apples with apples. We're trying very hard to build on and collaborate with and be compatible with other organizations and groups working in the field. We're enormously grateful for the collaboration support that we've received from NEST 360, and that was a big part of the data set that we settled on. Obviously, we're also continuing in the history of VON and ENN. And so it's not just about what data points you're collecting, but also very importantly, your data definitions. And we're trying hard to collaborate on those as well, so that although there are different organizations collecting data, hopefully a lot of our data is very compatible. Another issue which I think is important to discuss is there is a tension between, well, around how much data you collect, and there are many ways to collect data. So this form is the data that we're collecting on every single baby who passes through our neonatal unit. But in addition to that, we will also be looking at getting data annually from the units themselves, similar to a health facility assessment. So that will be more data about the resources and practices of the unit. And we also have the option for smaller, brief, standardized audits to look at issues in more granular detail as they come up. Next slide, please. And of course, it's not about data, it's about quality improvement, it's about outcomes. And so in the next 3 years, we're aiming to work through 7 key quality improvement areas. I mean, they're probably pretty obvious and familiar with you, but starting with family-centered care and kangaroo mother care, then antenatal collaboration, particularly antenatal steroids, neonatal resuscitation, what I call the golden hour or transition, particularly thermal regulation, infection prevention control and IPC, safe oxygen use for preterm babies, and CPAP. And I want to mention something that we have learnt from VON, which is the importance of family participation and family representatives. And I'm very proud to say that our family representative on faculty is probably one of our greatest assets in the African neonatal network. And if I have learned one thing so far, it is the value and the enormous resource that families and parents representatives are, and to involve them from the very start. Next slide, please. Yep, that's just our contact detail and QR to our website. So I'd like to hand over to Dr. James Cross from NEST 360, who's going to talk about the neonatal inpatient dataset.
Thanks, Alex. Hi, everyone. I'm Dr. James Cross. I'm a research fellow at NEST 360 based at LSHTM. I'm a clinical microbiologist and a data scientist. My current work focuses on the NEST 360 neonatal inpatient datasets, and I'm also co-leading the toolkit HSBB for infection. Today, I'll be presenting on behalf of the wider NEST 360 team on the NEST 360 neonatal inpatient dataset, its systematic development and multi-country operationalization for small and sick newborn care in low and middle income countries. I'd like to make a shout out to all NEST 360 country data teams and their leads, many of which are on the call today, and also Christine, Eric and Joy for leading much of the work you can see here today. It's also a very exciting day. After lots of work, we're releasing the NID as an open access adaptable tool at this seminar. So congratulations to all individuals involved in that process. Next slide, please. Sorry, next slide. So firstly, to take us through the story of how we got here, I'm going to talk through the situation relating to preventable newborn deaths, then how we've co-designed and developed the NID, and then highlight some advancements in regard to HR and infrastructure in relation to the data set, and then importantly then highlight how data is being used for quality improvement. At the end, I'm going to share the link to the available tools that you can download and start using today in your setting. Next slide, please. So as many on the call will know, 2.4 million newborns die each year globally, and 80% of these deaths are either preventable or treatable. At the same time, sadly, in high burden settings, we lack high quality facility level data, impeding the prevention of these deaths. One current international response to the situation is SDG target 3.2. However, with ENAP targets now aiming for 80% of districts to have a facility providing level 2 newborn care by 2025, there is a requirement for higher coverage of small and sick newborn care plus respiratory support for preterm babies. Currently, DHIS2 is widely used and typically uses ward registers and tally sheets to form aggregate data. However, tracking quality of care for more complex clinical conditions, these tools cannot include all the detail required to action a response on a newborn unit. In high income settings, there are multiple examples of standardized individual inpatient data sets and examples in high burden settings also. However, we found that there was a need for a parsimonious level 2 plus CPAP dataset to align with WHO standards and link to national data systems focused predominantly on quality improvement in the newborn ward. Next slide, please. So before I begin detailing how we developed NID, I just wanted to introduce the NEST 360 to anyone who's new to the Alliance. The Alliance aims to reduce deaths for inpatient newborns in support of SDG 3.2 and WHO UNICEF's QED initiative. NEST 360 is a multi-partner alliance bringing together national governments in 4 African countries with engineers, clinicians, and researchers and health systems experts. And the health system package focuses on innovation, education, policy, and is being implemented in 69 health facilities in this sort of multi-pronged approach to improving quality of care with data-driven decision-making at its heart. And facilities implementing NEST 360 have an annual newborn admission rate of close to 120,000 newborns, and now there's close to half a million records collected using the NID. In phase 2, with it not far on the horizon, NEST is looking to expand both in different facilities and in different countries across into Ethiopia and other countries, and whilst also continuing to collaborate with VON and ANA and others on the call today. Next slide, please. And just to touch on this, as many on the call will know, there are multiple levels of newborn care, and we need this whole package of interventions to turn the tide. However, with NEST 360, we are predominantly focused on level 2 care with the addition of CPAP, and this is where there is currently a great need. However, as you will hear later, the NID does have the adaptability to also have additional modules focused on level 3 intensive care going forward. Next slide, please. Now, to monitor and change small and sick newborn care level 2 care, indicators are needed, and indicators seen here are new and are now on the global agenda with WHO working hard in this area. However, many of these denominators are clinical and difficult to measure well. Next slide, please. However, with the use of the NEST 360 NID, we have been working on defining these indicators and are very happy to share and collaborate with others in this area. One indicator that I'm particularly passionate about is this infection sepsis treatment indicator. In NEST 360, we've done a lot of work in this area to try and improve our understanding of this difficult to measure indicator. However, it's clear innovation is likely needed. We require sepsis diagnostics and the improvement of routine use of neonatal blood culture in these high burden settings. Next slide, please. So to take you through the story of how we co-designed and developed the NIDs, firstly, we applied this systematic 3-step approach seen here on the left. In step 1, review, neonatal ward routine data tools such as patient forms, case notes, registers, and datasets were identified and reviewed in implementing countries. And then at the same time, we also found national, international, and study-specific individual level datasets that were identified and mapped by variable category. This led to step 2, which was co-design. The NEST 360 Alliance set a collection of a pylori design considerations for the design of the NID, and these include prioritizing data on clinical care pathways amenable to staff action on the newborn unit, a parsimonious core variable list, so roughly 50 variables per baby, and to support electronic data entry on site. Through co-design at a consensus building workshop with roughly 40 government policymakers, implementers, clinicians, these 300 possible variables were reviewed and reduced into 6 main categories, following which we had multiple rounds of expert written feedback and discussion and piloting, and this narrowed it down to a selection of 63 core variables. And these 63 variables and their responses were then adapted for the electronic data entry process. Seen here in the on the right here, click please, to show the 8 current modules. One aspect of the NID that we felt is particularly useful is the clarity of its branching logic, i.e. data collectors do not have to pick and choose where to enter data as they collect it, but in fact, the NID only shows variables are relevant based on previous data entered earlier on in the form. And we believe this improves completeness and timeliness of data entry. And finally, step 3, in terms of operationalize, the NID has been operationalized in, as I say, 69 units in 65 hospitals across 4 African countries with differing case mixes, hospital levels, and health system resources. And the NID links via an electronic data flow pathway to produce a live real-time NEST 360 facility quality improvement dashboard for the use of national and facility level teams. And I'm going to talk to that in the coming slides. But I just wanted to note at this point that something that was key from all participants in this workshop is that it was to ensure that, yes, we collected high quality, rich data that are important for supporting quality improvement. However, we did not want to risk being data rich, information poor, otherwise known as DRIP syndrome, where the collection of too much data starts to affect the collection, quality, and use of that data. We wanted a parsimonious data set, a data set that uses no more things than necessary. Next slide, please. So we co-designed a new tool, but probably most importantly, facilities require individuals to enter that data with high levels of accuracy and with great timeliness. Here, we just wanted to highlight 2 key learnings relating to NID implementation. Firstly, the use of specific government employed data entry collectors. This was learned from India's SSNC national scale-up process. And this shows an important task shifting approach that supports WHO recommendations to both strengthen and expand the health workforce, but also reduce nurse workload. Within NEST 360, the early leaders of this process were the Malawian Ministry of Health, and this came about through their national scale-up of neonatal care. The government has made a strategic investment to fund and deploy routine data collectors on the government payroll in all 38 newborn units, resulting in a huge increase in median timeliness of data entry from 49 to 6 days. And this country learning has had a huge effect and is now being taken up in Tanzania as scale-up begins in 2024. And lastly, one main learning relating to HR that we wanted to touch on here was that you can see here images of the first sets of data collectors being trained on in each country, much of which began within the COVID-19 pandemic. And this process used this training of trainers cascade model, with NEST 360 country data managers being the lead trainer promoting country leadership and ownership. Next slide, please. Now, to switch from human resources to infrastructure and the data collection pathway, the Malawian Ministry of Health has also led the way in implementing national level changes to standardized neonatal inpatient forms to align with NEST 360 variables. This adaptation has been key in ensuring that linkage between 2 national routine data systems. And now Tanzania is following that example in 2024. In regards to the data entry process, the method can vary with the NID, with some settings opting to enter data onto paper and then entering later into the data set, or some directly into the data set. And you can be done either on tablet or desktop. And it's worth noting at this point also that the Malawian government is now funding internet connectivity for the NID in newborn units across the country, and also importantly, housing the NID data on the DHIS2 server in the country. And here you can see the data collection pathway, which I won't go into too much detail, but essentially a summary of each admission that comes in on the left-hand side into a REDCap project. It then uses a API transfer into a central secure server where a facility quality improvement dashboard is made. But also importantly, there's a component which relates to data quality, which I've picked out here. And all of these outputs are produced with automated scripts, and the DQA report and query lists allows the server to mine the data set for errors related to completeness and accuracy. And these are then viewable to on-site data collectors to aid resolution of queries and assist in improving data quality in real time. And this data then links into existing country aggregate systems such as DHIS2 using automated scripts, allowing that flow of data up the healthcare system. Next slide, please. I just wanted to reflect on one of the outputs in that automated data flow pathway, the NEST 360 facility quality improvement dashboard seen here on the right. An early dashboard designs were used to inform the design of the NID, and the dashboard is developed using this open source platform RShiny to produce these data visualizations. And there's three main components, one being admissions and mortality, i.e. outcomes, quality of clinical care, the process, and then health system inputs, sort of the enabling environment. And this links with other tools that we have within NEST 360, such as the event log. And this then dashboard supports nationally owned QI processes at facility level with associated reports. And these linked outputs can then be used to identify and track, for example, low CPAP or blood culture usage, high rates of hypothermia on admission, newborn data gaps, such as analysis when we look at birth weight specific mortality. And this tool then links to a high level programmatic tool called NEST-IT, which I'm sure will be detailed later on within another seminar. Next slide, please. And now just to touch on this, but during the design process, we thought a lot about how the NID fits in the whole data landscape around SSNC. At the base of the pyramid, individual patient data are foundational to local quality of care, and much more detailed data are collected at this level and are individually linked, where the NID comes in. And at facility level, data are then key for planning service provision, supplies, and quality improvement. And DHIS2 data can then help collate core impact and coverage indicators to be used at district and national level. And as data moves up this pyramid, there is usually an aggregate data form by sort of population averages. And for SSNC, for example, at the top, it's ideal to have, for instance, the rate of newborn admissions, inpatient neonatal mortality rate. And these data can go all the way up through the system as a core indicator seen here in yellow. And they can be linked more to more detailed inpatient individually linked data, such as what we have in the NID, to track the quality of care when required. And this is hopefully where the NID fills that gap. Next slide, please. So I'm not going to speak to this too much, but in summary, the NEST 360 NID is co-designed with country governments in a three-step systematic process. We have a set of a priori design considerations before variable selection began. And we wanted to ensure that all NID variables relating to outcomes and clinical care pathways were included within the NID and really action this quality improvement process within newborn units and really rounding that QI circle. And so now it's been implemented, as I say, in roughly 70 units in Malawi, Tanzania, Kenya, and Nigeria, with many more countries and facilities to follow. In regards to the next step, the NIDs have been designed to focus on level 2 plus CPAP care to be parsimonious as possible. However, there is a demand for additional modules, both for different care areas, such as follow-up and, as I've mentioned, level 3 intensive care. And these are all planned for in the coming months and years ahead. Next slide, please. Now, it's probably the most exciting part of the talk today, but it's fantastic to say that the NEST 360 neonatal inpatient dataset is now freely accessible online at the link below. Also, you feel free to scan the QR code to gain access to the package of NID-related materials. This includes an overview document, a detailed and summary variable list, and then the REDCap data dictionary. And this can be taken and uploaded into a new REDCap project to begin data entry. We also have both of the paper forms in Excel format that can be adapted to the user's needs and printed and used thereafter. And finally, some inline images to help with the job aids, essentially. I'd just like to mention that we're also planning on releasing the 3-day training materials for data collectors within the coming weeks, and that we have our contact details seen here on the right. I hope everyone's got a scan of that. Next slide, please. So just want to say thanks for listening, and just to note that a publication relating to this process of developing and designing the NID will be released in the NEST 360 supplement at IMNCH 2023 in Cape Town in early May. And should everyone be interested in reading more, if not, feel free to reach out to me and the wider team if you have any questions. Thanks very much. Now handing over to Dr. Gagan Gupta.
Thank you so much, James. Am I audible?
Yes, can hear you clearly.
Thank you. Thank you so much. And thanks especially to Joy for inviting me. I am Gagan from UNICEF. I'm the Senior Advisor and Team Lead for Maternal Newborn Health at the UNICEF headquarters. Also to acknowledge Lily, who has been such a champion for not only small and sick newborn care, but also for this work on the databases. So thanks, Lily, for being there today for the call. Now, I will take a few minutes to speak about India's neonatal database and what have been the key learnings. I don't have slides. I will just speak based on my experience. India's neonatal database is now nearly a decade old. We started this in 2012. In this 10 years, it has now become the biggest real-time online database for small and sick newborn. But what is more unique about it is, first, it's fully government-owned. Second is, the real-time data is available at the click of mouse to the district teams, to the state program managers, to the national managers, and they can not only look at what's happening in the newborn care unit, but what also happens to the babies when they go back home, because it has a follow-up component for the first year of life. So it also lets us know what's happening to these babies in terms of survival, growth, and development when they go back home. Also, it gives idea of the human resources and the equipments in the unit so that we can make conscious decisions around that. Now, just to give a background, how we started, and also like a lot of work in India was learning as we were doing it. We evolved and we adapted. And this will also help in shortening the journeys of the other countries and the other teams who are working. When we looked at our newborn care units in one of the states of central India with a population of 72 million, the state was Madhya Pradesh. We realized we have been scaling up these newborn care units, but we don't know what's happening to the babies in the units. And once they go back home, we try to track the first cohort from the first 2 units. And we realized that after discharge, nearly 10% of the babies died. And most of the deaths happen in the first couple of weeks after discharge. Also, there were issues regarding stunting, increased prevalence of that as compared to the normal population, as well as developmental delays. Then we realized that we need to put in place a system that captures what's happening in the unit so that we can prioritize our limited resources for supportive supervision and quality improvement, identify the worst performing units and invest more on them. And then also within each unit, see where are the babies who have the maximum morbidity and mortality coming from. Like suppose we have asphyxia, then the database can track down to see in the district hospital which are the facilities which are sending maximum asphyxia babies. And then you can invest on skill attendance at birth, emergency obstetric care in those units. So the second thing which we realized was that when we have limited resources, we will need to prioritize those resources. So we started first in the first state in the 50 units, and then in 3 years' time, we scaled up into the entire country. Now, any data collection system, whether you do it in any of this, whether it's Vermont, Oxford, whether it's NEST, or whether it's any other database, it's essentially a 2-step process. The first step is to capture the data of every baby on a paper-based format. Now, once the systems mature, this step can be eliminated and data can be directly digitalized. But still, most of the countries whom we are talking in the current context, they have this habit where they try to have a paper-based data system. And first thing is that all units record the same variables. It should not happen that someone is recording it as a zebra and someone is recording it as a monkey. We need to have the same recording for the same variables across each unit. So standardize your case record forms in any country where you are working, whether it's your admission sheet, whether it's your discharge sheet, whether it's your follow-up sheet, whether it's your referral sheet, whether it's your newborn care unit register or the labor room register. And then you can also add a community follow-up card. So first thing is get your government convinced that in the newborn care units, we need to have a similar recording system across all units. Once that is done, constitute a technical advisory group who can look at the different sheets and variables available, compare and adapt according to the country's needs. Like in India, we don't use chlorhexidine, so chlorhexidine was not there. But when it is adapted to other countries, and Ethiopia has used India's data sheets, they're now using in 75 units based on India's adaptation, and Pakistan is doing so as well. So you can add chlorhexidine in context where it is applicable. So constitute a technical advisory group who can just work further on that part. Now, having done this, the second step is the digitalization of data. Now, digitalization of data will require a computer and an online internet connectivity in a newborn care unit. Most of these units are at district level, so getting a computer and internet is not a big issue. What is important is a person who can enter the data. Now, India went for a dedicated data clerk who was trained and who was doing the data entry based on what doctors and nurses have entered in the paper-based system. But over a period of time, you can also have a system where the nurses and doctors become so competent that they can do direct data entry. That will reduce the errors, that will improve the completeness, it will improve the timeliness. But as the system starts, you need a two-step process, a paper-based recording system and a digital data thing where you can feed the data. It's not very difficult to create that kind of a software which can give you an online form. And the second thing is it should have a dashboard which gives you an analysis on key parameters, be it the outcome, be it the admission rate, be it the duration of stay. So it's a combination of two things, a paper-based system, a digital system where someone enters the data, and that digital system should provide an analytical dashboard which can be used by the program managers, by the unit itself, and by the policymakers in terms of actions. Now, what helped in terms of India in facilitation was first the need. There was a clear need that we were making newborn care units left, right, and center, but we were not knowing what's happening, as I said. So the need was obvious. Second is seeing is believing. When we created these units, 50 units, we invited other state governments. And when they started looking at this, they said, we also want in our state. So some of the states like Maharashtra, Gujarat, southern states, they were the first to take up this database. The third thing was we were able to convince the government to take a policy decision to have this in the budget lines of the district budgets and the state budgets. So there was a dedicated budget line which will have a data operator budgeted, the cost of the stationery, the cost of running it included in the government budget line. The fourth thing was, as I said, the dedicated data operator to enter. And we also were tracking the timeliness and completeness. And we could see that where the data operator was pulled out of the unit to do multitasking, then we had to make sure that that data operator was brought back to do the primary task. The fifth thing was using this data for policy actions. And in the interest of time, I will just restrict to two policy decisions that were taken based on this. The first one was the labor room initiative. When we showed to the government the data that the deaths in about 2.5 kg, asphyxia becomes nearly 70% as a cause of the deaths in the babies who are above 2.5 kg. A baby above 2.5 kg doesn't require to be in the newborn care unit, and B, shouldn't be dying. So a lot of this happens in the labor room and before that. And then Government of India started a whole program called Laksh, the Labor Room Quality of Care Initiative. Second was about the antibiotic usage rate. We had initially antibiotic usage around 70-75%, while sepsis was around 30-35%. Over a period of constant monitoring, it has come down to 50%, but still is pretty high. And the third thing was access of the girl child to the newborn care units, where female admissions in some of the states were below 40%, which was much more, even if you take into account that the girls are biologically stronger. So those things helped in also looking at the policy and the programs. Besides the fact that there was a regular review by the state and the national government, on the state would do quarterly review, the national government will do an annual review. Ideally, another important thing is the review by the own unit. That was like patchy, to be frank. Sometimes they will do it, sometimes they will not do it. But definitely the data was used by the state and the national government. Now, moving forward, and some of the challenges which we often come across, or the questions which we are often asked. One is, how do you link it with the DHIS2 and HMIS? Now, we need to understand that there are two different systems. DHIS2 or HMIS will give you cumulative data of the performance of a unit, that in a year, X number of babies got admitted, X number died, you can have causes of death and all. But to get that pool data, you need a patient-based data. And this is what it does. It gives you individual patient-based data, accumulates into a pool, and that pool can easily feed into DHIS2. There are utilities which are available by which you can export data from one system to another, and that can be easily developed at the country level. Second thing is getting the data from the private sector. So in one of the states which had a very strong private sector presence and an insurance scheme supported by the government in the state of Gujarat, we were able to get private sector enrolled with more than 100 newborn care units. And that is something which countries can look at, is if you have an insurance scheme, if you have a public-private partnership mechanism, those private facilities can be asked as a part of the agreement to give the data. And third, as I said, is the regular use for action and the data quality. Data quality is always an issue, especially on some of the parameters like assessing the cause of death, which has a lot of variation. But over a period of time, when such a big pool of data is there, generally you are able to get that diluted and you can still get a good kind of an inference from the whole database. So I think this was in a nutshell what we try to do. And it has helped also other programs. And I remember when Joy was in India and Nest was there, we shared our variables, the case recording formats, the dashboard, and I was myself there for a few meetings of Nest while sharing this kind of work which we did in India. So I think we need to do a bit more, and I hope that we move forward on this. Thank you so much.
Thank you. Thank you very much, Gagan, and to all our speakers for today. It's very useful insights and also different experiences from various parts of the world. So thanks very much for those who already posted some questions to the speakers today. I think some of the questions we've tried to answer on the webinar, but this is, we now have a few minutes to look at those questions and have a question and answer sessions. So if you haven't put anything in the chat, please feel free to also use the raise your hand feature and we can ask your questions live. But allow me maybe to just start with those that are already on the chat. And there's a question from Rakesh, which was, I think it's been touched on both by Gagan and James on the integration between some of these key data sets with the DHIS2 platform itself and how they are linked and whether they are linked by API. So I think Gagan noted the differences between these two different data sets. One is obviously for example, the need and the data set that the Vermont Oxford have talked to us about today are individually linked data sets. And the DHIS2 data set is aggregated data sets. And the idea is that to try and being able to keep the richness of individual level data sets for individual level patient care, but also being able to push some of those key indicators into an aggregated DHIS2 system that is in use in a lot of these countries. And those efforts are already happening within countries, at least for Nest 360. And I'm sure from the ANA group, there's efforts to try and link those two. So they're somewhat different, but actually the two different systems are communicating with each other. I don't know if maybe I'll start with from the ANA side, if you wanted to comment on that, and then James, maybe you can come in as well if you have any additional points on that. Alex?
Yes, thank you. Yes, I think that is the fundamental question is how can these things be aligned? I'm not an expert on DHIS2, and I'm also will be telling you what I've heard second or third hand. But I think DHIS2 is a big institution and is not, it's a big train in motion and not that easy to sort of add your little pet projects as you go along. Not that any of us are doing pet projects, but I think it's a major undertaking to start modifying or joining up with DHIS2, but I think that is the goal going forward. However, as I mentioned before, in the meantime, what's important is that we collect the same information with the same definitions, which is already going on, and a collaboration in progress between Nest 360, VON, us, and also going forward with UNICEF, so that all these things are compatible.
Thank you, Alex. And I also note that some of the country teams that have actually been having discussions on how to kind of integrate some of the need data sets into DHIS2 are also on the call. Maybe I'll invite Josephine, if you are able to speak, and maybe you could reflect some reflections from Tanzania, perhaps. Josephine, are you there?
I think you have the wrong Josephine, sorry.
Yes, Josephine Shabani is on the call.
Yeah, thanks, Eric. Thanks, everyone. So actually in Tanzania right now, the government is on the move of like harmonizing all the systems, electronic systems, so that we have only one system up to the national level. And actually under NEST, we have already started some efforts of having the neonatal register, which shall be used for all the facilities from district hospitals up to the tertiary, so that we have the joint efforts towards the combining and integrating all the variables into the national system, the DHIS2.
Thank you. Thanks,
Yeah,
Josephine. Thank you, Josephine. James, did you have anything else to add to that, or should we move on to the other questions?
I was just going to add that we have been working on this, especially with Malawi, in terms of trying to bring all of that individual data down into an aggregate form with automated scripts, which can then be used. And I think that's been useful with on-site data collectors, because it's on facility-based on-site data collectors, because it's ensuring that they don't have to do the same job twice, which is then getting a lot of buy-in in facilities and helping that process run smoothly. Yeah.
Thank you very much. Rakesh, does that answer your questions? Do you have any follow-up from that? So the question is, can see your post, is the individual database system free to adapt for needy countries if it is, sorry, to adapt if it is already developed and used successfully in other countries? Sorry if I missed this. So yeah, the answer is yes. So I think the purpose of, as James shared in one of the slides, is actually we've launched all these tools and they're available as global public goods. They're all available on our newborn or a newborn toolkit as well. And we're happy to share those links as well. I think Toby has been sharing those links, which you can click and visit and be able to have access to all these materials for adoption by for any different for your different countries. So thanks very much. Okay. So I'm going to move to the next question from Gillian, and please feel free, if you have any questions, please also use the raise your hand facility, and I'll call on you to ask your questions. So Gillian was asking two important questions: whether, for example, from Latin America and the Caribbean, if this data collection system has been trialed in these settings. And then the second question is this system compatible or adaptable with the PAHO developed perinatal information system that is commonly used in that region? So I perhaps can answer the first question, which is to say that we haven't trialed this in Latin America region. Obviously, as you say, that we are making available all these tools as global public goods. They'll be available for adoption by the different countries. And the team, the NEST 360 team, are very happy to work with anyone in how best to do those within those different settings. So we're very happy to have follow-up calls on this. I don't know, Joy, do you want to comment on this second question, which is again is asking whether the system is compatible or adaptable with the perinatal information system in Latin America? I don't know if you have any comments on that, Joy.
Yeah, thanks so much. And actually, it's like going back in time, I think in the 90s when I was at CDC and had the privilege of working with that group in Latin America and was just with some of the leaders recently. Yeah, I think there's so much to learn from that system. I think the difference there is that's primarily from the maternity end and then linking to the neonatal. I think in the rich learning from Gagan, the India database started from the neonatal and realized the importance of linking back to maternal and to follow-up, which is really important. So I think all these systems have, particular purposes in how they start. And one of the things that James highlighted is particularly when you're starting in a place where people are really struggling with data overload and not enough people, that sometimes starting small in one place and making that work well and then linking is a good place to go. I would say another thing that the Latin American group have done extremely well with the SIPS database and also with PAHO is systematically to include the ROP, so retinopathy of prematurity, and India also have done that. I mean, so much to learn. You know, and I would say that one of the really important things is that the end destination is to be national data sets, that, you know, India is covering the whole continent of India, which is like the whole continent of Africa. And our hope out of this with ANA and Vermont, Oxford and NEST and working with UNICEF and others is that we can futurecast for a data set in Africa where we start small, but we can speak to each other across countries and across units and really deeply learn together and act together. And I think to do that, starting small and then adding these other things afterwards is really critical lesson. So really fantastic session. Thanks, everybody. And so much to learn from, you know, from Latin America, from India and across Africa together.
Thank you. Thank you, Joy. Mita, may I ask you maybe if you could go to the, I think it was a second slide, which has the links to the Newborn Toolkit. I think it would be helpful just to show that whilst we're taking the question so that people can at least be able to refer to those and use those links, click on those links as well. So the other question, thank you, Peter, for your comments, very wonderful comments. And the question from Peter is if there are any experiences to share on integrating the digitized forms in health facilities operating existing electronic medical record systems. So great question. Maybe from a, if I may take this one from a NEST perspective, is across the many facilities that we've been working with, some of these facilities actually are those that had already existing electronic medical records. And what we've done is to work with these facilities to integrate whatever is already existing into the standardized need data set. And then from that, as James was speaking to, we've then be able to link these data sets being collected to real-time dashboards that are then made available at the hospital or facility level for use to inform data for action efforts. We're also working towards ways of how we can track those key indicators. There was a question that was asked, which was very excellent, on how can we make sure that actually we can track these key indicators and looking at things like effective coverage. So all that is actually things that we're able to capture within our existing dashboard, and also a new programmatic tool dashboard that's just been launched in the last few weeks, which is able to actually track some of these indicators with targets as well. So a lot of that is actually coming together, and we are very happy to work with, you know, for example, facilities or countries that already have existing medical systems into a kind of a standardized form, and then maybe leverage on some of the work we've already done on the dashboards and how we can best track that. And Christine, maybe if you are able to say maybe one or two things about the nested, perhaps, on how we are using that to track some of the key indicators and how it links to the quality improvement visits.
Sure, yes, Nested is a new tool that we have just launched that summarizes data at the program level across all NEST countries, at the country level, and also the facility level, that allows users to look at key indicators that were co-designed together based on our learnings from our quality improvement initiatives, to look at those over time, so to see trends, to see and compare facilities, so you can see positive outliers, facilities that might need additional support, and also to look at these trends against targets that were set together. So we're very excited because this really helps us at a program level to hone in on which areas are performing well, which areas need more overall programmatic support. And then, as I mentioned, at the individual facility level, these are able to be used by facilities as part of their QI projects, their QI meetings. You know, they would be able to print them out, the run charts, and annotate them in meetings, and really use them as a practical tool to guide their quality improvement work.
Thank you. Thanks, Christine. And then we've got 1 minute left, so I'm going to quickly ask Danielle. I think you can see your hand up, and maybe Alex before we close this session. Thank you.
Yes, thank you. Alex and I maybe will chime in on the same thing, but just saying how important this is, I think, to work together from the start. We've been working with colleagues at OpenMRS, Neotree, Nest 360 to compare the apples to apples, oranges to oranges, and to map all of the elements into the development of electronic medical records. And really, as Joy mentioned, thinking forward, thinking of a future where we're all working and learning together. So really highlighting the importance of that and the wonderful opportunity to be doing this together.
Thank you, Danielle. Alex, last one.
Danielle, that's pretty much what I want to say, but I will add one more thing, which is FHIR. I'm not an IT person or an electronic health record person, but you make them very happy when you say FHIR, which is FHIR. And the electronic medical record systems, as long as they are FHIR, they can talk to each other. And so if you want to be knowledgeable and clever like me, when you go into these meetings, just go FHIR, 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 and people will be happy. And I'm happy to say OpenMRS, Neotree, they're all FHIR compatible, so they can all talk to each other with minimal fuss.
Absolutely. Thank you very much. And I think on that note, we're going to bring this wonderful session to a close. And again, as you can see that for those who've joined us for the first time, this is one of many of this series that we've run in the past. And there are more upcoming similar seminar series, which you can get and contribute to. Also, we request you to visit our Newborn Toolkit website and also sign up for our newsletter where you get information about our upcoming seminar series. But allow me to say that the next seminar series will be on family-centered care, which is a very important health system building block, and that's going to be on the 13th of June. So please do make sure that you join us for that upcoming seminar as well. Otherwise, I'd like to bring this to a close and want to thank all the speakers for today and also thank everybody for attending. And if you have any follow-up questions, please feel free to email us, and we're very happy to work together with you. Thank you so much and have a wonderful day.